Hey, everyone. Thanks for joining the EMS Academy. For those I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU provider, physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County and have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, on behalf of the EMS office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, thank you guys. Thank you for what you do every single day. Thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, who is a young member and volunteer at Pikesville, who is helping us with our Zoom platform. Ashley is also the one who is going to put a link in the chat later on in this training. Click that link, fill out some information, get your MIEMSS CEUs. If you have any questions about or difficulties filling out the form, getting to the link, completing the form, any questions about your MIEMSS CEUs, please hang out with us after the training, and we'd be happy to help you and answer any questions. We're not able to add anyone who's unable to sign in tomorrow, so I'm so sorry. We need to resolve all of that before our training ends tonight. I'm sure you understand. So super excited to have with us tonight three of my favorite people: Scott Goldstein, Kos Hamburger, and Dennis Krebs. Scott Goldstein serves as the director of Masada Healthcare Consulting, specializing in workplace violence prevention, verbal de-escalation, and healthcare-specific self-defense. With 38 years of experience in the fire service, he is an instructor evaluator for MIEMSS at the University of Maryland, MIEMSS Services, EMTB Evaluator, AHA BLS Regional Faculty and Director of Training, Emergency Volunteer Project. He holds numerous certifications in fire and EMS service. Kos Hamburger is a paramedic and member of the Chestnut Ridge Volunteer Fire Company. He has been ALS provider since the early 1980s and has served as both ALS mentor and instructor on various capacities over his decades with the volunteer fire service. He is a trained mediator specializing in alternative dispute resolution, conflict management, and crisis negotiation. He has a lifelong interest in public health and emergency medicine and is a graduate of Johns Hopkins University, Baltimore, with certifications from the Center for Research on the Epidemiology of Disasters at the School of Public Health in Brussels. He is the author of Two Faces of Richard, documenting the most extensive face transplant in history, and is currently working on an independent long-term project on trauma at R. Adams Cali Shock Trauma Center. He teaches part-time for Masada Healthcare as an instructor in workplace violence prevention and verbal de-escalation at the MedStar Health System. Dennis Krebs is a retired captain and paramedic with the Baltimore County Fire Department. Following his 30 years in the fire service, he worked as a tactical medic, supporting various federal law enforcement special operations teams. He has authored numerous books, including When Violence Erupts, A Survival Guide for Emergency Responders, and Medic Up, Where Criminals, SWAT Teams, and Medicine Intersect, and also various other articles on violence toward fire EMS. You guys are my heroes. Thank you so much for being with us tonight. Thanks for sharing. I think I'm handing it over to you, Scott. Thanks so much.
Okay, thank you. Thank you, everybody, for coming out this evening. So if anybody was listening to our calls being dispatched out today, this topic popped up twice today. So first we had a backcountry rescue. Crews were told to stage because of the incident up in Cockeysville while police assessed the scene. And then there was a firebox in Rosedale where reported subject inside lighting the house on fire, running around with a .22 revolver. So fortunately, we were given heads up on these. Sometimes that doesn't happen. And sometimes when we get there, the people that we deal with are going to be a challenge. And we're going to go into tonight, we're going to do a little review of what we talked about last week with the verbal de-escalation of the workplace violence, but then we're going to get into specifically how to deal with very specific incidents. And we're not going to be able to tell you how to handle everything. There's not going to be an automatic go-to. We're just going to try to put a lot more tools in your toolbox. And so when that Rolodex starts rolling around in your head to figure out what's going on with them and what to do next, that you guys have some better understanding of what these folks are going through and how we can provide support and actual care for them. All right, Kos, if you want to go ahead and pop that up there.
All right, let's see if we can get this to work. Can you see my screen?
Yes, sir.
Excellent. Okay. All right. This evening, the objectives are going to be a follow-up to the talk that we gave just before the holidays. We're going to explore which techniques and approaches are most likely to de-escalate patients, and we're going to focus on those with special needs or special populations. They cover a lot of the same techniques, but some of them are going to be situational specific, and we'll go over that. We're going to talk about and re-emphasize the importance of situational awareness. We're going to mention the term situational awareness over and over and over again tonight. It cannot be overestimated, the role of how important that is in potentially hostile situations. We are aiming to strengthen the culture of patient safety and care, which is something that all of you do on a regular basis, and also to introduce what might be new for some of you, the concept of trauma-informed care and the role that plays in de-escalation, and also the role that plays in the way that you deal with your patients in general and with each other and ourselves. And we're going to talk about that. And then finally, to maximize the likelihood of physical and emotional safety for all of you that are involved in the care of our patients. Now, opening picture, a quiz. Oh no. So these are easy. Don't stress over it. And there are only 3 quick scenarios. The first one, you are dispatched to a call of an unconscious patient. You arrive on the scene and the wife is standing at the door and she says, I was talking to my husband and suddenly he said he wasn't feeling well. He dropped to the floor and he's been unconscious. Please hurry up and come inside. You walk inside and you find the patient pale and you go down and do an assessment and you find the patient is pulseless and apneic. What is the first thing you are going to do? Somebody yell out or put it in the chat. And Sean, you can tell us what they say. Anybody?
So far, they're just happy birthdays for Scott.
Okay. What is somebody going to do? This guy
Start CPR.
Begin CPR. Excellent. All right. And then immediately your second crew comes in and they're carrying an AED. And they hand it to you. What are you going to do with the AED? You're going to put it on the patient's chest. The pads are on the chest and it says shock advised. What are you going to do?
Shock.
Excellent.
Push
And
the button.
Excellent. The patient wakes up, opens his eyes and says, where's my wife? And she says, right here. And you take her to the hospital. You take him to the hospital and he does well and is discharged 3 days later with an automatic internal defibrillator and does well. So that's scenario number 1. Wasn't particularly difficult. Let's look at scenario number 2. You get dispatched for a trouble breathing call and you arrive on the scene of a party for a bunch of teenagers. And one of them is lying on the ground. She looks awful. She's pale. She has profound respiratory distress. And she has a medical alert bracelet on that says allergy to peanuts. And she is lying down next to a half-eaten Reese's peanut butter cup. What do you do? Any responses?
Not yet. They're coming.
Okay.
Epi.
Exactly.
Epi.
Right. So the reason why in that cardiac arrest and in that respiratory distress anaphylaxis patient, we gave CPR, we gave defibrillation, and we gave epinephrine is because there is evidence-based medicine based on peer review research that tells us exactly what we can do and what works. Unlike the rest of what we're going to talk about tonight, emotionally ill subjects de-escalation does not have evidence-based medicine, evidence-based research. It has anecdotal research. And it's interesting, there was a study done by the Brits that looked at 346 different papers, all of which had to do with how to de-escalate people in various states of emotional compromise. And not a single one met the standard of evidence-based care. So tonight we're going to talk about best practices. We're going to talk about reasonable approaches, but none of this stuff is evidence-based. So there is no right or wrong. It is scenario specific. And some of this stuff is very much by the seat of your pants. There are a set of tools that we're going to give you that are probably universally applicable and available to you in order to de-escalate a situation. But again, this is not evidence-based, it's anecdotal, and that's an important distinction. Okay, so tonight we're going to be talking about people who have special needs, special considerations, or special patient population. And that includes, but is not limited to, people on the spectrum with autism, We're going to talk about people with Down syndrome. There should not be an S there. It is actually named after the English physician Down. Traumatic brain injuries, behavioral medicine that includes patients that suffer from schizophrenia, paranoia, dissociative disorders, and big shout out to Brianna Snyder, who gave a talk here a couple of weeks ago and did a fabulous job. I interviewed her for this presentation and she was invaluable in her assistance. We're going to talk about depression, bipolar disorders. We'll briefly touch on how people can manifest when they are suffering from dementia, delirium, and delusion. We're going to talk about language barriers and how that may play into our ability or the lack of ability to communicate effectively with patients. We're going to talk about drug and alcohol abuse. We're going to talk about the importance of ruling out other medical conditions, metabolic conditions, diabetes, neurological, and a few others. And finally, this is really Dennis's strong suit here, we're going to talk about the role of de-escalating patients with PTSD, notably military, law enforcement, and you could argue some firefighter and healthcare personnel in there as well, and the special significance that is required in treating these patients. As a matter of brief review, you remember scene size up is just a critical part of what we do every single time. If the goal of all of this is to get us home safe at the end of the shift, we must be meticulous about doing patient assessments as well as threat assessment. What is it in that scenario, in that scene, that potentially can be seen as a threat against us? And then redoing a patient assessment in order to verify the patient is stable or not, and redoing a threat assessment as the room changes, the scenario changes, the environment changes, and the care of the patient changes. And so a golden rule is that scene size up is never static. It's never over until the call itself is ended. And the golden rule is always expect the unexpected. And so situational awareness, the critical component of this is starts before you ever get to the scene. Intelligence gathering is key, and that starts with the information that dispatch gives us. Never assume that the information is correct. It is a starting point. It is not an ending point. And then when we get there, intelligence gathering on the site, verifying that it comports to what we think it probably should be. And then we're going to go and aggressively look for potential problems. Don't get caught up with tunnel vision. It kills people in the line of work that we do. Maintain safe distance, physical distance when we approach the scene, when we approach the patient, until we verify that it's safe to approach closer. And verify who else matters and where are they? Are there family members that are in other parts of the room? Is there another way for them to get in, and is there a way for us to get out? We're going to talk extensively about situational awareness. And scene safety. It starts with seeing their hands. If you can't see their hands, you might not see your future. And this is just really critical. In this tunnel vision, we had an exercise a couple of days ago where we were talking to some security team members, and we were right up in their face, and literally they missed seeing a gun tucked in a belt 6 inches away from them, because we developed tunnel vision and we're not doing a constant threat assessment from head to toe. So recognize this is something, a trap we fall into. And know when to leave. Know how to leave, know when to leave, and know how far away to go when you are leaving. We talked last time about clearing weapons. That's a task for law enforcement, not for us. And ultimately, it's that old gut feeling. If something doesn't feel right, it probably isn't. Scott or Dennis, you want to talk about weaponizing our tools for a bit?
So I'll jump in. There's any number of things that.
Sorry, didn't realize I was on mute.
Any number of things that we carry on us, as you can see in the slide there, that can actually be used against us. We bring a lot of these things with ourselves. One of the biggest things, both in hospital and out of hospital, that we both in hospital staff and on the street, is the stethoscope thrown around your neck. And that winds up, if you're leaning over someone and they grab each end of that, they've got control of you and you're not getting away very easily. And in a bad situation, think about trying to leave that in a pocket or someplace else as opposed to around your neck. Center punches, knives. If we discount knives. And I show knives when we do in-hospital classes and ask people if they see a clip on somebody's pocket, what does that indicate? And quite often I get, well, it might be a ballpoint pen. No, it's a knife. And even small knives. Remember, box cutters brought planes down on 9/11, and those are only about a ½ inch blade. Something like what you see in that picture there can do devastating damage. I generally show pictures of a conscious male on the street who was eviscerated with a knife that size. Police officers that were cut across their back with a 2-inch wide incision across their back from a knife. And a lot of times, once you get cut, you don't even know it. As one police officer described it, I didn't even know I was cut until I started to see blood below me. So you may not know you're cut. All these things can wind up causing you problems. And if I can drop back one of the previous slides about intel gathering en route, in my infancy as an EMT, both myself and Mr. Berkowitz, who happens to be on with us this evening, ran a call in the Pikesville area for a child who had fallen out of a tree. When we arrived, we found a 24-year-old man who committed suicide with a firearm. How 911 got that out of what we found, I don't know, but do not run into things thinking what you were dispatched on is what you're going to find.
Yeah, absolutely. And one of the things, some of us are still carrying pouches. If we've got the trauma shears or the Lister shears, in this case, the hemostat, those are very easily grabbed by somebody while they're on the stretcher and we're sitting on the bench seat, and suddenly we find those in our gut. It happens all the time. The literature is filled with it, and you have to be aware of it. Don't bring our tools to the bedside and allow patients to grab hold of them. And then Scott, you want to cover this one? Weaponizing the contents of the medic.
So during COVID, a lot of us emptied out the back of our medic units and had very small bags. But still, there's lots of things back there that these folks can get their hands on. So in this particular situation, our ambulance was sent to a elderly high-rise in Pikesville, typically not a high-threat environment. Crew's upstairs working, we get a knock on the door, or they get a knock on the door. They said somebody's down there ransacking your medic unit. The smaller of the two providers decides to go downstairs and investigate, and she goes down there and confronts the individual who's in the back of the ambulance. He's unhappy with that and rips the sharps container off the wall, the large one, throws it at her. She's now ducking into the bushes, trying to get away. Fortunately, she got far enough away because it exploded and needles went everywhere. Her partner heard the commotion. She got on the radio. Then you see the aftermath with the police coming there. But during those couple of minutes, he decided to empty out all the contents and just have his way with the ambulance. Again, the person that lived there was a son of one of the residents, obviously history of behavioral health issues, had no part of this call whatsoever. And then next thing you know, she's now running for her life, trying not to get hit by needles that we have no idea where they came from. So again, when we're working both within the homes and within the back of the ambulance, if they can reach it and they can put their hands on it, they could probably turn it into a weapon. And so be very cognizant of that.
So again, is the scene really safe? When you approach, make sure you know how you approach, where you're going to approach, and how you can get out. So approach with ingress, recognize that there are doors and windows. Look in the windows if you have the opportunity first to see what's going on inside there. Stay to the side of the door, stay out of the kill zone. And last time we actually talked about the paramedics that were, the paramedic was killed down in PG County. Know the difference between concealment and cover. That's where you can hide and where you actually get protection. The motor block of a car or the medic unit will offer you protection. The door will not. And are you easily identifiable as fire and EMS? These days, we're finding a lot of people are not being very kind to people in uniform, specifically looking police officers. And unfortunately, we have uniforms that look very similar to that. So we are all thrown into sort of one basket. It used to be that we were given special consideration because we were there to help people. Today, that's no longer recognized. And do you have all the pertinent information about the scene, the occupant history, and firearms, exactly as Dennis just said? Do you have an unblocked way out? Are there other people that might pose a threat? And again, always expect the unexpected. So why do people get angry? There are lots of reasons, but the ones, if you look at the literature, the ones that constantly sort of rise to the top are power struggles, an overreaction to threats, real or perceived. It's posturing as opposed to other people, and posturing as opposed to us, or emotional displays that are inappropriate for the level of challenge to the emotion. People don't feel like they're being heard, and they feel that they are not being listened to. There is a tremendous pandemic of disrespected feelings. We're going to talk about that in the context of trauma-informed care. And people feel threatened. So a busy slide, let's look at it just for 1 second. Can you see my cursor move?
Yep.
Okay, excellent.
Yes, sir.
So this is known as the behavioral continuum. If somebody is sitting quietly at your station, they come over to the station, they're sitting quietly, they're in a state of calm. And there's nothing you really have to do about that except just sort of keep an eye on them. As time goes by and as their level of agitation increases, they become anxious. And at that point, you have the opportunity to verbally de-escalate. And those are the techniques we're going to talk about again in a little while. If they are not de-escalated and the stimulus for their agitation continues to hit them, then they will become increasingly agitated. At this point, it's either verbal de-escalation with an awareness that you are running out of time and you may have to consider egress or additional resources. And then finally, the person snaps and becomes physically aggressive, at which point they are either a danger to themselves or they're a danger to you or others around you. And that requires rapid egress, a potentially defensive maneuver. The reason why we have on this side, the reason why we have this vertical line is that many people assume that this behavioral continuum going from calm to anxious to agitated to aggression is a slow or a 45-degree angle. It doesn't need to be. Somebody can go from 0 to 100 in a matter of seconds, and we have to be aware of that. And finally, after an event occurs, there are consequences of that event, and that phase is known as recovery. First thing, obviously, is care for the caregiver. Are you or is one of your team members injured? And if so, they need to get care. Is there an emotional injury component to this thing? If so, they need to get care. There's resource allocation. If you have an EMT or a firefighter who's injured, and you now have several of your teammates who are taking care of that person, those are fewer resources that are available to take care of the patients or others who are injured. And finally, the most important thing is to look at is patient safety, monitor vitals. So after the patient has been de-escalated or restrained, which is the last choice you want to make, but if you have to, you must monitor the vital signs. And when we look at the literature of why public service and first responders get in trouble across the nation because their patients died, it's most of the time it's preventable. It was because the patients' vital signs were simply not monitored appropriately. So we're going to talk about that as well. Okay, let's look at some clues and cues. What are the giveaways that we are potentially in danger and your patient is becoming escalated? Scott, you want to handle this one?
So that picture right there is the 1,000-yard stare. They might be staring right at you, but they're looking through you at something else. So first off, I would turn my head and see exactly what they're looking at. They may kind of give you an indication. It may also be they're staring through you because they're formulating a plan of what they want to do next. Like who said, let's look at their hands. Now, if I'm making a fist, I usually have two options: knocking at the door or taking a swing at trying to hit you. So do they have enough space that I can just simply step away so that can't happen and allow me to get out of there? Or am I in a position that I can deflect it? Or have I not paid attention and now I may have to actually force my way out of a situation? Arms braced, that means they're kind of closed off. And you can really pay close attention to people's body language and other cues and not just what they're saying, because what they're saying may just be a distraction. Pacing. They're pacing back and forth, they're plotting something, and they're looking for an opportunity to do something next. That's kind of our time to disperse, evacuate, get everybody else out of there. My personal theory over the years is push my crew out of there, make sure I'm the last one out, and we'll separate, and then we'll come back in. We're not abandoning a patient. We're regrouping, making it safe, getting additional resources, then we can re-engage as it's appropriate. Twitching. So again, we're looking at something that's in in context of somebody's behavioral posture changing to agitation as compared to a medical twitching where you're thinking a seizure type activity. This is where the stress is getting to these folks, and depending upon their history and how they handle it, it may cause some sort of a facial tic, some sort of a body part twitching. In context, I would be very concerned, and we're kind of right at that point, right below peaking. Lack of focus or hyper-focus. Hyper-focus is kind of that 1,000-yard stare. Lack of focus, again, they kind of checked out of the environment and they're kind of in their own head. And so it's not going to take much for us to stimulate them in a negative way. One of the worst ways that we tend to aggravate people is with the tone of our voice. And those that have been in my classroom share that pain. But legitimately, and we see this at all levels, both pre-hospital and in-hospital. And you guys, how many people have told me this over the years, right, Caps? It's not what I say, it's how I say it. But that really is quite a bit of it. That's where the disrespectful tone comes in. And that's where we had an opportunity to not even let this happen. And why is that happening? Because we're running another one of these types of calls. We're running another sick subject. We just ran a service call to, bring somebody water, and then we got cleared, and now we're taking it out on the next patient. Whatever it is, we got to make sure that we know what our demons are. We got to know how we're coming off to folks, because simply our voice and our nonverbal cues could be just enough to put these folks in a already bad situation, and now they have something to focus on.
Perseveration is always the tough one. It's where people are repeating the same concept or the same words over and over again. So an example of this would be somebody who maybe is, you arrive there and they say, I want to hurt somebody, I want to hurt somebody, I want to hurt somebody. And they just are repeating it over and over again. And they are completely unaware of the fact that you're there. Or if somebody is rocking back and forth, then they are repeatedly using the same rocking motions. That's always a hard one. Dennis, you want to cover posture, personal space, and clothing not consistent with environmental?
Sure. So generally, you want to stay about 1.5 hours distance away from people until you've got a good idea as to your safety. Obviously, at some point, we have to go hands-on, take blood pressures, start lines, run EKGs, things like that. But in the initial interview, being 1.5 hours distance away gives you a little bit of reaction time. And in my When Violence Erupts book, we talk about an interview stance where instead of standing directly in front of somebody, where if they kick or hit, they can strike center body mass and hurt. You stand off at about a 45-degree angle with your body turned to the left or cocked at a 45. And you can wind up, if they do hit or strike, you can, they'll hit soft body tissue. As Scott mentioned, for the person that you're dealing with, their own posture, is it stiff? The fists and clenched teeth, those kinds of things are indicators that they may become physically violent. The other thing too that we often hear about in the past is folded arms as a cue that they've shut off communication. And some new things that I'm seeing, which sort of involves me, and I had been in situations or scenarios with the military where I was pulled out. We were running an exercise and they thought I had shut off communication because my arms were folded. In some of this new thought process, there are a number of people, myself included, that their normal posture, that of comfort, is to have their arms folded across their chest. That is comfortable for me. So you can't necessarily, just because a person has their arms folded, necessarily believe that they shut off communication. It may be that is their norm and their comfort. You have to sort of take that in with other things that you're seeing as far as their body and their overall demeanor and how you're going to address them individually.
Super. And then the last line, clothing not consistent with environmental conditions. This is where you're looking at somebody, it's summertime, they've got a trench coat, or which leads you to suspect there may be something underneath there. Or conversely, it's freezing cold outside and they're walking around in their underwear. Clearly that's a sign that there's some problem there, and it raises your level of suspicion. So right. So the 7 C's of crisis containment. This sort of is the guide for how you can get a situation under control. If you take a look, there's a green line going through it at a diagonal. Everything to the right of the green line is a required action, and everything to the left of this green line is your desired result. So in order to get to this side, you've got to ensure that these requirements are met. The obvious one is calm. Provider has to remain calm. There's the old adage, the first pulse you take at a cardiac arrest is your own. That's the same thing in these de-escalation situations. Take a deep breath, literally, to orient yourself and to evaluate the situation and come up with the best possible plan of action. We have to treat people who do not act towards us with civility. We have to treat them with civility. It's the only way we're going to move forward. And the reason why the word tactical is in there, it's tactical civility. We are going to treat them in a way that buys us the end result for which we are looking. So even if it's hard, even if it's counterintuitive, we are doing it with the express purpose of gaining the tactical advantage in the negotiation. We have to be credible. If we offer a promise of something, food, blanket, communication, additional family members, if we offer that to them as part of the negotiation or as part of the de-escalation process, we must be able to deliver. If you lose credibility, you can never regain it again. So that one matters a lot. And compassion. I mean, we all got into healthcare because, number one, we like writing things that went, that lights and sirens, but principally because we are people that care about others. We have compassion as a fundamental philosophy that guides us in the way we deal with other people. And we can't lose that. So even when people are frustrating and when they are violent or potentially violent, we still have to show compassion under difficult circumstances. And that's hard to do. And in exchange for calm, civility, credibility, and compassion, we are looking for the person to provide cooperation, effectively a buy-in to help us out on their behalf, collaboration, they want to work with us and we want to work with them, and compliance. We have to set the context of what we want them to do. I want you to allow me to take your blood pressure. I want you to come with me to the hospital. I want you to release a hostage. Whatever the situation is, we want to gain their compliance. So again, it's an ongoing cycle. And in exchange for those, we remain calm. So you see, we continue to treat them with civility. We continue to offer them things with credible options. And so this cycle continues. Okay, so the goal of de-escalation overall is using both verbal and nonverbal techniques to reduce tensions and conditions which are inhibiting appropriate medical and emotional care. So if we get called to the scene to treat a patient and their behavior is such that we can't get access to them, then we can't provide them with the care that they necessarily need, whether it's the emotional care or whether it's the pharmaceutical intervention, whatever the case may be. And or these are contributing to dangerous conditions for the patient and for us. So these people are in crisis, and you're there to offer care, you're there to offer comfort, you're there to maintain their safety and yours and those of the people that are on your team and their family members. And ultimately, these are short-term solutions. The only point is to resolve the crisis of the moment. You are not there in order to provide them long-term therapeutic interventions. And sometimes it's kind of enticing for us to get involved with, well, why do you feel this way? And tell me about your background and so forth. It's the inappropriate way to deal with that. Leave that up to the therapist later on down the road. Context matters. And the reason why we highlighted this bottom one in green is it's really important. The only goal you're trying to do with all of this stuff is to bring the temperature of the room down. You are not trying to win an argument. There's no argument. You are simply trying to offer them the best possible care you can. So busy slide. I'm just going to go into it sort of superficially. Crisis behavior can be, we always look for acronyms. So the crisis behavior can be identified through something called STAMP. That is staring and stance. How are they looking at us? Are they looking through us? Are they looking beyond us? That's when Scott was talking about the 1,000-yard stare. That's sort of the classic one. And that, by the way, is almost pathognomonic of somebody with PTSD, post-traumatic stress disorder. We'll talk about that shortly. Tone. What is their tone in terms of communicating with us? And of critical importance, what is our tone in reflecting back to them what we hear them say, active listening, how we're going to approach them? What is the volume of their voice? When people get anxious, when people get agitated, their volume goes up, the speed of their text gets faster. And so their volume and tone can tell us a lot about their state of agitation and how is it changing. We're looking for anxiety. We're looking for mumbling. Are they able to articulate their words? Is this a way for us to put their neurological status in context? Is there a way for us to use mumbling as a sign to evaluate their emotional context? And then pacing. We've all seen the patients that are sort of pacing back and forth. They're rocking back and forth, part of that perseveration, physical perseveration again. And these are all considered validated tools for emergency care evaluations in emotionally unstable patient. And so in order to diffuse the aggressive patient, we use some of the basic tools. We use verbal techniques. We remain clear and calm. It speaks for itself. It's obvious. And even though it's obvious, when we look at it on the PowerPoint deck and when we teach these things in classes, we forget about being clear and calm when we are tested in a real life environment. Focus on that. Use non-threatening body language. We are the product of a psychological profile that we create for others. If we stand there with our chest facing them and our arms crossed or our hands crossed, and we are looking big and we're making fists because we're nervous, the body language we are showing somebody else is different than using non-threatening by turning slightly sideways, maybe at a 45-degree angle. Our hands are at our side and open, and one foot is behind the other. And this allows our hands to protect us if we need to. It makes us less large and less threatening. And with the foot behind us, it gives us the Muhammad Ali sting like a butterfly, float like a bee type thing. We can step back when we need to if we're suddenly approached with physical violence. Treat everybody with respect. And even if they're yelling at us and they're calling us every name under the book, recognize that they are angry at the world. They are angry at the situation. They're in pain. They are suffering from a whole host of potential maladies. But treat them with respect anyway. And it's really hard to do when we're being challenged like that. Look at nonverbal and verbal tools for early detection. Again, we've been talking about that. Look at how the patient seems to us and what are they trying to tell us with their general body stance. Create a sense of trust. Like I said before, credibility is critical to an effective negotiation. Set limits. Tell somebody what you expect from them, why you expect it from them, and don't let them get beyond that. Finally, environmental controls. Make sure that you keep the lighting to a minimum. Lighting is a potent stimulus. And if you think about it, we approach in a big red truck with lots of flashing lights and lots of loud noises. And the most important inciting factors in some of these special patient populations is harsh lighting, loud noises, and loud conversations. So it's kind of
if I can jump in on a couple of things in reference to that slide. So years ago, within my street survival course that we were doing around the country, we would often talk about a lot of these situations, not changing what's going on inside of the house, shutting your lights and siren down about a block or so beforehand. That way, if there's a domestic argument that you're coming into, they're still arguing because they didn't see or hear you coming. So the light and noise issues in that respect, but also when you get there. And a bit of an example, I guess it was back in the 90s, medic one had gone out on a call right after shift change. We got dispatched to assist them. And as we arrived, the medic unit was there, one lone police car, and a police officer came to us and said that it was an emergency petition. Gentleman said he was going to fight, so they needed more hands. And I asked him, could you give me just a couple of minutes and let me see what I can do as opposed to fighting? So went in and find a large gentleman, probably about 400 pounds, naked from the waist down, sitting on a couch in the living room. And the first thing out of his mouth was, I'm not going, you're not going to make me, and I'm going to fight you if you try. So we wound up that I started talking to him. I sat down across from him got to his level, had eye contact. There was a coffee table in between him and myself, and I just sort of figured that it would take a lot more for him to get up and across that table, and I was a little bit more agile than he was at that point. So tactically, I wouldn't necessarily do that all the time, but in that case, I decided to do it, and just sat there and talked to him, and quiet, and just talked. And at one point, I found the one thing that worked for him. And I made the statement, look, you go down to the hospital, the doctor talks to you. If everything's okay, then you come home and you prove your family wrong. And that was about 20 minutes in, and he went for it. That worked. And he went to the hospital. A little funny anecdote, sort of after I had him saying yes, he mentioned, hey, can I ask a favor? Sure. He said, can I get something to drink? I'm awfully thirsty. And somebody off the medic unit behind me made the statement, no, you're going to the hospital, you can't have anything by mouth. And nearly blew everything that I had built in the way of a bond between myself and this guy. And I turned around with a very stern look on my face. And at that point, if he wanted a peanut butter and jelly sandwich, he was going to get it, because I wasn't getting my butt kicked. But talking to people, and you know, as Kuz mentioned, you know, body language and being quiet. Only if you've got something like this, one person's talking, only one person. Whoever seems to have a bit of a connection, that one person, give it to them, let them run with it. That's
Dennis, that's a great story. Thank you for sharing that. Coach, can I ask a question about the other side too?
Of course, yeah.
Yeah, so when you say, you know, set clear limits for patients to follow and don't let them cross that, can you give an example of that?
Sure. If you determine that a patient may not leave a room, then you have to tell him, I'm happy to discuss with you, I'm happy to talk with you, I'm willing to work with you, whatever we need to do, but I can't let you go into another room because it wouldn't be safe for me and it might not be safe for you. So let's go ahead and do that here. And once you establish that limit, then that really is one that you have to enforce. And, you know, if you explain to somebody why, frequently, not always, frequently they'll buy into it. If you don't make it arbitrary,
Yeah.
explanations go a long way. And again, one of the things, and we'll talk about this sort of later on, but one of the things to keep in mind is that all of these negotiations are attempts at resolving an issue. They work 70, maybe 75% of the time. That means that there's 25% of the time they don't work. And that doesn't mean those end up being hands-on. There are only very few percentage that actually end up being hands-on. But they're not completely successful where you are getting what you want and they are getting what they want. But if you determine pre-existing limits, you need to stick with those.
Thank you. Great
Sure.
example.
Okay, and obvious things. Don't take this personally. They're angry at the world. They're not angry at you, even though you're on the receiving end of that. And take a time out if you need to. And that's either for them or for you. Silence can be an effective negotiating technique. Just take a deep breath, ask them and tell them, you know, when I take a deep breath, I feel better. Maybe we can both take a deep breath here for a second and reset and see if we can, you know, if maybe I'm not understanding what you are saying clearly enough because I'm having trouble, and let me see if I understand you correctly with active listening and talk about that. But literally take a couple of seconds. It has to be 30 seconds, that's fine. And just let things quiet down and do a reset. And respond, don't react. You want to think about what you are doing and what you are going to do next. It's a bit of a chess game. And so you don't want to be the person that's constantly reacting to their stimulus. You want them to think about and sort of work towards the stimulus you are trying to give them, and you want to respond that way. And then the other one is very similar to the first one. Don't take it personally. If you know, rapport is critical. Dennis has said this in various times before in other settings. Rapport really is critical. If you don't feel that you're making an advance, then pass on to somebody else who might do a better job. Okay, so this is just a repeat of basically what we said before. Rapport, credibility, and tone are the keys to this. Show empathy and compassion. Avoid the triggers once you know them. And the key line, the second to last line here, avoid the term "I understand." When somebody is in crisis and they are telling you something and they are no longer grounded in the same reality in which you find yourself, telling somebody else "I understand" will elicit a response which is, there's no way in hell you can understand what I'm feeling right now. So if you have somebody who's becoming violent because they just lost somebody in their family, maybe you have lost somebody and you genuinely have had a similar experience, but they can't know that. And so by telling somebody "I understand," you are forcing them to say, "No, you don't." And you are building a wall between yourselves. So rather than that, say, "I appreciate the experience you just went through. Tell me how it feels and tell me what I can do to help you get through this." Don't tell them you don't understand, even if you do.
One thing I'm going to chime in real quick, Coach, is we're talking about and we're focusing on patients, but don't lose everybody else around you. Sometimes our difficult patients are going to be better managed by some of the family members. So if I can connect them with a rapport with one of the family members, come up with a plan with them, that might kind of get me where I need to go. And constantly pay attention to these other family members and folks as they're stepping in and out, especially if things are starting to escalate.
Right. And remember, the goal of all of this de-escalation stuff is to prevent a physical confrontation, if at all you can do that. So we use a protocol.
Somebody writes in the chat, "I hear you" is a good response.
Absolutely. But then finish up that thought, which is, "I hear you, and let me verify that I hear you correctly." And then literally rephrase what they said back to them, paraphrase what they said back to them. And follow that with, "Am I correct in what, do I understand, it's a different context. Do I understand correctly what you were telling me?" Right? That's not the same thing as "I understand." It's verifying that what you heard them say is in fact what they wanted you to, what they wanted to transmit to you. So you are confirming that. And it's the most important part of active listening. We use the SAFER model. There are many different models. Protocols require the SAFER model. Stabilize the situation, and I would add situational awareness under the S. Assess and acknowledge the crisis. Facilitate resources, which is part and parcel of what we do all the time. Bring in extra people. Encourage the use of resources, and recover and referral. Get them to a hospital. We have talked about the RAP. I want to keep our time in mind. We've talked about the RAP, which is another acronym: recognize, accept, and plan. And again, recognize the person's problems, recognize what we are bringing to the situation, accept, which means to show them kindness, compassion, respect. Hard to do when you're being challenged. And finally, 2 plans. 1, the plan that we are going to execute now in order to de-escalate them. Can we get them some food? Can we get them a blanket? Can we call a family member? Can we offer them warmth of the back of the medic unit if they're outside? Something for this moment. And the most important part of the plan from our perspective is, what is our plan if the de-escalation fails and we find ourselves in physical danger? How are we going to make egress? So always keep that in mind. Okay, we're going to skip over this one. And we went over, just real fast, we went over the use of force continuum. If your de-escalation efforts fail and you find that you are forced to go hands-on, preferably it's a law enforcement issue, but if there's nobody there, just basically look at this chart. It is the key consideration chart that all law enforcement and use of force experts use. Imagine this with a target, a line going straight vertically and a line going straight horizontally with the target in the center. So a quick identification: you've got the situation that you're trying to resolve. In order to resolve that, you are assessing the situation. As a result of that assessment, you are planning your next step, and then you're going to act on that plan. And that is a constant circle of events. As the event changes, your assessment changes, your plan changes, your act changes. And in terms of what you are doing and why you are doing it, in this quarter, the patient is cooperative. When patient's cooperative, that is your perception they're cooperative, and you do lots of communication. There's very little physical. The yellow is physical intervention. If they become passively resistant, will you please come to the medic unit with me because it's cold outside? No, I'm not going. All right. In that case, you want to continue to communicate with them. You may want to consider gently guiding them if they allow you to or not. If they become actively resistant to you, they are pushing you or walking away. They're not pushing you, they're walking away and they're actively resistant to coming. Then you continue to talk with them. You can ask for additional resources. The police might use some more physical control, and may you think of potentially using a taser or something along those lines. If they become assaultive, the police department can use harder physical interventions, can consider intermediate weapons. And finally, the option of last resort is lethal force. So if you don't have the police department there and you are only left with yourself and your colleagues, this is the guiding principle. We should almost never, ever, ever even consider this area except as an absolute last choice. All right, option of last
And
resort.
one quick point on the use of force continuum. If you are attacked, using the words stop, 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 you just tried to de-escalate a situation. Make sure you write that in your reporting, because that is a version of de-escalation. Are they probably going to stop at that point? Probably not. But in the eyes of everyone else, and you know the way we can be second guessed, you can put down in your reporting, I tried to de-escalate the situation. It was fast, stop, 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 but you tried.
Absolutely. And Dennis, if we take a look at the large letters here, document. So use of force, the option of last resort, you can only, from a legal perspective, you can only use defensive force that is commensurate, fancy term meaning the same as the level of the threat. So if somebody hits you, punches you in the nose, and you have the option of walking away, you walk away. If they are holding you in such a fashion that you have to push them away, then you push them away and walk away. You can only use the force that's commensurate with the threat and use the least amount of force necessary to facilitate egress. That is a legal requirement. If you come back and say, and I don't appreciate the fact that you did that to me, and give them another punch, you are now going to set yourself up for legal ramifications. A jury of your peers has to look at a totality of circumstances, everything that went into your actions, and verify that your only option was the one that you took. If you use a greater amount of force when you had the option of using a lesser amount of force, you are going to be in trouble. So will a reasonable person in a similar situation have taken the same actions, yes or no? And again, as Dennis said, absolutely with 100% accuracy, document, 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 and the legal terms contemporaneously. That is, at the time of the event, when it is safe to do so. When the lawyers look at this, they will tell you that anything that you write as close to the event as possible shows the most accurate reflection of the event. If you wait the greater amount of time from the event, the less reliable your memory is going to be, and the less reliable you are as a witness. And then obviously you notify chain of command. Okay, let's talk briefly about trauma-informed care. A new approach, at least new for us, and it's an approach of care that recognizes people, all of us, are the sum of our experiences, some of which may have been traumatic and may have resulted in a variety of manifest and hidden either adaptive or maladaptive behaviors, emotional disturbances, and that includes somatics of physical complaints. Trauma-informed care affords an environment of care based on physical and emotional safety, empathy, empowerment, and critically, avoidance of re-traumatization. So there are lots of ways that people are traumatized, and the general direction of trauma-informed care now follows the same thing that we are doing with PPE, which is we are, each one of us, when we go to a call, we're gloving up, we are masking up, we are doing eye protection if there's a possibility of bloodborne. And we do that because we assume that all people are bloodborne pathogen positive until proven otherwise. The approach to trauma-informed care is that everybody has been traumatized in one way or another until proven otherwise. So it is safer to use trauma-informed care. Think of it as the emotional PPE in the way that we deal with patients. And in the special patient population, which we're going to get to right now, parents, caregivers, healthcare workers, and coworkers are subject to significant traumatic events. Trauma-informed care recognizes there are basically three parts of this thing. The effects, which are objective. What is it that I objectively was subjected to? I was a victim of an earthquake. I was a victim of gun violence. I was a victim of poverty. I was a victim of, the list goes on and on and on. Subjective experiences, that is, how did I experience it? So all of us are in EMS. If we see somebody who is laying on the ground and they are bleeding from a gunshot wound, we treat them, and if this is the 4th, 5th, 10th gunshot wound we've seen over the course of our career, then we have a pretty good understanding of what it is, and it doesn't faze us as much as somebody who is seeing an act of violence on their loved one for the first time. It's the same objective event, single gunshot wound to the chest, but our experience for this event is different than somebody else's experience. That's subjective. And finally, recognizing that all of these traumatic events carry effects that are either emotional effects, they have the cognitive effects. We can't think clearly. Think of COVID, where we were all sort of locked up in our houses for a while. It affected our ability to sleep. It affected our ability to interact with other people. It affected our ability to do the work we wanted to do. It affected our memory. It affected, the list goes on and on. There are physical effects. Those are the somatic effects. There are cultural and social effects. So one of the things that we want to talk about is this thing called intergenerational violence and intergenerational trauma. When we are looking at why are people being disrespectful more so now than at other times, or when people come into the hospital, when people call EMS, they are being disrespectful. Part of it is, for example, racially motivated. If you are Black or of African-American descent, and your great-great-great-grandparents were brought here against their will as slaves, the trauma-informed care model suggests that there is a component of the trauma that each of the subsequent generations from that slave generation brought, and there's a residual now. So your ability to feel disrespected or to respect others is dependent in part, either consciously or subconsciously, on that. If you are Jewish and your grandparents, great-grandparents, or parents were part of the Holocaust in Europe, then your ability to deal with that scenario, to listen to how people talk about related items are directly related, are directly affected by your being like that. If you were Native American and your great-great-great-grandparents had their land taken away from them by white colonialists that came over from Europe, that may affect the way you feel respected or disrespected, or in turn offer respect or disrespect to others. So this intergenerational, or it's called epigenetic trauma, is a significant issue now that we are looking at as a root cause of one of the root causes of the violence we are running across society. And then trauma can be as simple as a simple injury, that we see this all the time: illness, grief, loss, abuse, disaster. Can you imagine what these people in Turkey are going through now as a result of what they're doing? And that is going to have long-term consequences. Poverty, and then vicarious trauma, we're going to talk about just in 1 second, and ACEs, which are adverse childhood events. So if you look at the numbers of people that have learning difficulties or that go on to be incarcerated, and you look at the adverse childhood events that they suffered, there's a direct correlation between that. Let's finally talk about vicarious trauma. This is something that's particularly important to all of us, because what do? We see the rest of society in their most critical periods of medical, emotional, and physical disrepair. We are constantly listening to other people's complaints, other people's illness, other people's problems. And so when we do this, we are building upon ourselves a box of traumatic events that happen to others, but that we are partaking of as a, once removed. And that builds up on itself. And so that is called vicarious trauma, and affects us, those of us in the caregiving environment, and specifically those of us in the first responder and field environment and field workers. So recognize that within ourselves and within each of the way we deal with each of our colleagues. And so the trauma-informed care model influences our cultural sensitivity, including the perception of respect and disrespect, as I've already said. Religious restrictions. So what happens if we need to partially disrobe somebody and it's against their religious preference to do that? Or we are of one gender and we are touching somebody of another gender for the purpose of taking a blood pressure, for the purpose of taking a pulse, and it is against their religious beliefs to do that. What about the concept of compassionate touch? Are we re-traumatizing somebody when we intend to show that we care? We are placing a caring hand on their shoulder without asking them first, is it okay if I put my hand on my shoulder, on your shoulder? Suppose this person was inappropriately touched in the past and we don't know about that, then we are re-traumatizing them. And the concept of trauma-informed care says to us, ask them, assume that there may have been an issue, and verify it's okay to touch them. And I would argue that that should be part and parcel of our caregiving methodology, unless the patient is critical, with every patient. May I take your blood pressure, and explain what you're doing. I'm going to put a cuff around your hand. It's going to feel tight for a moment. Because again, if they've had some kind of traumatic event in their past, we want to give them as much information as we can and empower them with the choice. Yes, you may touch me. Yes, you may do medical procedures on me, or no, you may not. So compassion, touch, and interview space. If we don't think about the potential consequence of doing a history in the back of a closed unit when somebody potentially was abused and locked in a closet, and we notice on their facial expressions that they are getting the twitches that Scott talked about before, or they are perspiring, or they look uncomfortable, we have to at least consider the possibility maybe this person had a traumatic event in a closed space. So, you know, we need to be aware of that. And one of the things that might be useful and not always ideal for us, but nonetheless, I'll float it out there, is asking somebody when you see them, you do not need to tell me what it is, but is there something about me, or is there something about this space that makes you uncomfortable or makes you feel less safe? And if so, what would you like me to do about that? Would you like me to get another provider, a female perhaps? Would you like me to have somebody hold up a sheet when I do an exam? So just consider these things. And then finally, trauma-informed care makes us aware of the fact that there are certain people that have been subjected to trauma. And we, as first responders, all have a mandatory reporting, for instance, of child abuse, sexual abuse, and elder abuse. And we have to maintain our awareness of that. Okay, autism, spectrum of disorders. Every patient is different. The most important intelligence gathering we can get is usually from the caregivers, and we should also listen to verbal and non-verbal cues from the patient. One of the biggest problem with autism is as the children get older, their cognitive and behavioral age doesn't change, but their body size does. And so now you've got a very large person who has a very young and maladapted cognitive ability, and that creates dangerous scenarios. So for most of these people with autism, they are hypersensitive and hyperreactive to what we would consider normal stimulus of the environment, or they can be hyposensitive and hyporeactive to the normal environment. And a study that was just done in Israel, it was released last week, actually puts on its head the concept that people who have autism have less sensibility to pain. That's why they can hurt themselves and continue to do things that cause pain. And so the study concluded, we know that self-harm could stem from attempts to suppress pain. And it could be that people with autism hurt themselves to activate unconsciously a physical mechanism that pain inhibits pain. So it actually suggests that this population is actually much more sensitive to pain than we anticipated. Also, triggers, fear of the unfamiliar environment or persons, and that includes us. You know, we are showing up in order to help them, but it's difficult for them to understand that. They don't know us. And so we need to be able to integrate into their environment in a way that might be helpful. That's not always doable. Noise, smells, light, and touch. Touching a person with autism can be highly problematic. And so the approach is to ask people who know them best for advice and information, decrease the stimulus. As Dennis said before, in all of these situations, minimize the number of responders that are trying to do an interaction. Have one person try and create rapport within the safety constraints. If somebody's going to be violent, you don't want to be by yourself. Maintain a safe distance when safe to do so. Reduce the objects for self-harm or weaponization. So if you are in an area where somebody can pick up glasses and pick up books and pick up whatever, computer tablets that they can throw at you, that's going to be an issue. And so recognize that. If somebody's laying down on the ground and they are on the spectrum, there is nothing wrong with laying down on the ground at a reasonable safe distance from them and allowing them to see that you are willing to conform to their world and their perspective. That may buy a lot quicker quietude than if you approach them and you're standing and they're lying on the ground looking up at you, which is quite terrifying. Use short, simple declarative commands. This is not a group with whom a conversation is going to buy you anything. Unlike somebody else who you're trying to negotiate down through a conversation, This is a group where just telling them what you want them to do in very simple, clear terms will give you the best chance of accomplishing your goal. Like any of the other groups, tone, volume, and pace makes a difference. You should speak slower than I'm speaking now because I'm trying to save some time. And then redirect with a safe task. If somebody is doing self-injurious behavior, give them something else that might pull them away and redirect their thoughts. Hand them a teddy bear. Give them their music. A lot of people with autism have their earbuds. Give them music earbuds and let them hear music, a blanket, etc. I'm going to show you a quick video.
This is where he's put his head through the wall, And this is where he stood and kicked it. £52. He can go through this house and just wipe everything out probably in 10 minutes. You know, turn furniture over. Well, you see all the windows and stuff. You know, the air conditioner back in the bedroom. He'll sit and punch that till it's in pieces. You know, in other words, if it breaks anymore, it's kind of like it's material. It can be replaced. I don't even let it bother me. But the destruction is just unbelievable.
Coach, it's super hard to hear. I don't know. Are you hearing gaps too?
Okay, Sean, say it again. Sean?
It was very hard to hear. It was very poor audio.
Oh, okay. In that case, we'll skip to that one. It gives you an idea. And so ask yourself how, if you get called to that residence for a patient that is out of control, how are you going to relate to that patient? How are you going to deal with that patient? I'll show you a short clip of a successful de-escalation. If you can't hear that, just yell out.
Yeah, can you also maybe turn off your video? I think not your video. Yeah, your personal video. Turn your picture off because that decreases.
Okay. Is that better?
Well, yeah, like
Find out.
start stop video, not just.
Okay.
You know what I mean?
Yep.
Yes.
Better?
Yeah, now try to play it.
Come on, 10 seconds. Here we go. 10, 9. Keep going. Good. Faster, faster. Good. Bend the knees. Bend the knees. There it is. There it is. Come on, Robert. 5 seconds. 5. Correct position. I need you in the right position. Robert, listen, Robert. Listen. Yeah, I know. It's frustrating because it's hard. I need you to finish 10 seconds the right way. Robert. Deep breath. Deep breath. I'll wait. I'll wait for you to take a deep breath. We can wait. We're just going to wait this one out. Oh, there. Good job. Take another.
Okay, so with regard to that one, when he put his hand on the shoulder, the recommendation when I spoke with the Autism Speaks community, they recommend not putting a hand on the shoulder. Aside from that, it shows that you are willing to wait, give the person a chance to reorient, to reground, and that is effective.
You can turn your video back on too.
Okay. And then, unfortunately, because we in the first responder community are not as aware of how these patients present themselves, there are catastrophic results. This is a situation where in 2020, a patient who had severe autism hit his father. The father called the police, or had somebody call the police department. The police department arrived, could not figure out how best to deal with this guy. He slapped a police officer, and they all piled on top of him and put him in a chokehold. And ultimately, after 9 minutes of a chokehold, the patient died. So, we really must maintain a level of awareness. And that goes beyond just the EMS community. If we see that police officers are having a hard time, it is our responsibility to look out for the patients. And so perhaps, again, this becomes a crisis negotiation itself, but perhaps offer them the possibility that this is a medical issue rather than a criminal issue. And although they must be there to help you restrain a patient if the patient is dangerous to you, at the same time, do whatever you need to in order to verify the patient's vital signs are stable and the patient will end up surviving the event.
So two things super fast. So one, your video is still off. If you just want to slide your protector, maybe.
Yep. Thanks.
Number two, Dr. Sikorsky comments to you specifically, couldn't agree more with the same eye level. We use this technique with Baltimore inner city youth children's hockey for crisis intervention. Sitting on the ice and speaking with them is an extremely effective communication skill, more than any other.
Absolutely. Absolutely. Thank you for adding that.
One thing I'd like to chime in, because one of the things when you guys first get there, the family's used to dealing with these folks all the time. If they're making a 911 call, it's usually because the providers, some of them have reached overload and they're not able to handle it anymore. So you may actually have multiple patients that we need to assess, possibly treat, possibly separate, but making a quick assessment of that part of the environment is going to be very helpful, because that person may actually be the trigger for your patient, and because of what happened prior to our arrival. So that's going to be kind of a key intelligence gathering.
Yeah, absolutely. The Down syndrome, when I spoke with some people about this, there's a significant issue in terms of the nomenclature and respect. And so the preferred nomenclature is a child or a person with Down syndrome, rather than a Downs person or a Downs child. The emphasis should be on the potential of the child or the potential of the person. Therefore, that comes first, and it is Down syndrome without the S. So I wanted to put that out there. And this is simply, it's an extra, either whole or part of the 21st chromosome. It's the most common genetic disorder. There are ways of testing for it. Some people continue the pregnancy even though it's already been diagnosed. And again, like autism, there's a spectrum. Some people do very well. Some people with Down syndrome do very well and have long lives. Others are more profoundly affected, and it has both intellectual, learning, developmental delays, as well as a whole host of physical components, GI, cardiac, and there's a strong component of early onset dementia in this population. So because some people with Down become frustrated quickly, they may occasionally become aggressive. It is not an inherent part of the syndrome, but it is possible, just as a result of frustrations or inability to make oneself understood, that it causes some anger and agitation. And so again, stimulation may sometimes help focus or block out unwanted intrusive stimuli. So they will stimulate themselves. It's called self-stim. And it can translate itself into attention-seeking behaviors, not all of which are socially acceptable. So yelling is an issue, masturbation, public masturbation is an issue, etc. And these are calls for self-soothing in a way that we don't fully understand. And the strategy when people are acting like that, when people with Downs are acting like that, then the recommendation is to ignore and again redirect. Be aware of the situation, be patient with these people, be compassionate, and compliance frequently may take longer, and it's not because they're not going to comply, it's because it takes longer to understand what that compliance looks like. So don't be in a rush, it may still yet be forthcoming. Unfortunately, and we talked about this briefly during the last class, here in Frederick County, there was a gentleman who was 26 years old with Down syndrome. He loved movies. He went with his caregiver to the movie theater. Caregiver went back to the car for a second, and he tried to sneak back into the movie theater. Security guards were not happy that he snuck back in, and they ended up calling the cops. He ended up on the floor, suffered a fractured larynx, and died as a result of asphyxia. There is a common thread here, and again, it is our responsibility as first responders in EMS to make absolutely sure that the vital signs of patients that are being handled in restraints are secure. These things are entirely preventable. So here's a situation where, because the behavior was not appreciated for what it was, This patient ended up dying. Okay, TBIs, traumatic brain injuries. Frequently there are outbursts, kicking, hitting, self-injury, loss of sexual inhibition is quite common with both children and adults with TBIs. It gets worse with fatigue. A lot of times the ability to differentiate between night and day is lost, and so circadian rhythms are lost, and there's a chronic fatigue. Fatigue exacerbates the receptivity to triggers in this population. There's memory impairment, so you can tell somebody, please do something, and it's not that they don't want to do it, they've already forgotten or have not been able to process what it is you're asking them to do. So again, patience makes a huge amount of difference in trying to deal with these people. Take your time. There's no rush in any of these things. Nobody's telling you have to get there at a certain amount of time. Overstimulation, it's hard to filter out the noise from the signal. Comprehension is difficult. We talked about that. And give somebody a brain break. Give them both space and time to reorient, to process at a slower pace than we are used to what it is you are exacting from them and what it is you are trying to do for them. They need to be able to identify that you are there to help them. This is not intuitive to somebody who is not able to process well anymore. So deep breathing, speaking slowly, and active listening, including reflection. Do I understand what you are telling me? Is my appreciation for what you're telling me correct? Dissociative disorders, again, much appreciation to Brianna. She went over that. And I just want to cover briefly what she didn't quite cover. And I'll tell you what prompted the question in my mind is if you have somebody who has parts, for those of you who were not here for part of the last, for Brianna's class, dissociative disorder is the new name for what used to be multiple personality disorder, where you have one individual who, through some traumatic event or secondary event, has a series of sub-personalities known as parts. And so they can have a child part of them, and fully functioning adult part of them, a mischievous part, a dangerous part, a peaceful part. It depends on how many different parts they have, and they all work together in some symbiotic way. But the question I had is, if you need to de-escalate somebody, and it doesn't happen often because there is generally this is not an aggressive population, but if you need to de-escalate somebody and you are facing the 6-year-old part and you need to de-escalate and you find that you'll make much better progress talking to the 30-year-old responsible part, can you do that? Can you summon that part forward? And Brianna was hugely helpful in helping us, helping me guide her through that. And the answer is yes, you can. And in the conversation I had with her, the most common complaints that her patients have about EMS is that caregivers don't treat people with dissociative disorders and other mental disabilities and mental disorders as a person. They become stigmatized, they feel humiliated, and it exacerbates their condition. So in terms of what can we do for this patient population, the most important thing we can do across the entire board is treat people in a way that they deserve to be treated, and that they don't go into the hospital feeling that they were in some way or another treated differently because they have a mental disorder. Humanize them, we talked about that. And then Brianna said something which I paraphrased, because she was talking about nurses, but I paraphrased it, and she said something very important. Every patient deserves a first responder who wants to be there today. Show that you care, and this is my addition, show that you care even if you can't understand. I think it's really important. If we're at the end of a shift and we've had several really, lousy calls, and then we get a call for an emotionally ill person and we really don't feel like dealing with it, we don't want to show our dissatisfaction with the way the day is ending with this patient. Every patient deserves to be treated as if they are the most important patient of the day. And it's hard for us to do. Trust me, been there, done that. But it's important that we do that for providing the best care we can for our patients and show a non-judgmental attitude. I'm going to, again, limit physical touch, reduce stimuli, and grounding is the key to regaining the trust and regaining this patient population back to the current space. And you can use an ice pack in their hand and tell them, do you feel that? And it brings them back to a stimulus they feel that they can control versus a stimulus they feel they can't control. And you ask them, look at that ring on your finger. If they are presenting you with their 6-year-old part, and you tell them, would it be reasonable that your 6-year-old part is married? Look at the ring on your finger. That should tell you to please bring out your safe adult part, and we can discuss with them. The key being safe, because if there are unsafe parts, you do not want them coming out. That compromises your safety and theirs. So always say something to the effect of, I can see you're scared. I need a safe adult inside to come forward and help us handle the situation. And be sensitive to re-traumatizing. This is a particularly difficult group for which restraints need to be applied. Please be judicious about that as a really last source, because many of these people have been horrifically traumatized before. And I will show you just a quick example of grounding. I will stop my video. Close this. Hopefully you can hear this.
Well, they came to my house on Tuesday. Yeah. To go into so much detail.
Just come back to me. Just come back to the room. Can you just look up? Check it out. Let's try to get you back into the room. So just look around the room. See this painting that's up here. What do you see? Can you tell me what the painting's of? Yeah, a beach.
Sun.
Yeah, cool. Okay. Throw it back to me. That's it. That's it. Good. Just throw it back to me. Just see if you can stay here and also listen. Okay, so just want you to keep in the room and keep it. Sometimes it's a bit stressful.
So in that scenario, he is trying to bring her back to the present place rather than take refuge in one of her previous parts. We can do the same thing by giving a person a toy. Many of us carry stuffed teddy bears on board the medic unit for the child population, pediatric population. So we can use this for that population as well. Cover real fast: behavioral health disorder, schizophrenia, paranoia, bipolar disorder, and depression, suicidal ideation. Again, allow yourself the time necessary to respectfully deal with these patients. This is not the time to say, we're almost at the end of shift, so let's just hurry up, grab this person, and either get her to sign a refusal or race them over to the hospital. Give them the time they need to deal with the situation they have, and use the standard de-escalatory techniques that we were talking about earlier.
Can you turn on your video?
Yep, it should be on.
Maybe the privacy.
There you are.
Okay. And then an important line here: developmental disabilities may affect many areas of functioning, including thought, behavior, speech, and sensory development. Most people with developmental disabilities are not violent or aggressive. That's really important for us as EMS providers to understand. Most people are not going to be violent or aggressive. They may become violent or aggressive based on what we are doing to them or causing them to feel that we are doing to them, but it's not an inherent part of the disease process. And some people with more severe disabilities may experience high levels of frustration, which can be expressed through both aggressive and self-injurious behaviors. Okay.
Question for you, Coase. Do I have to know the diagnosis? Do I have to be correct about what these folks have in their condition for me to interact with them properly?
No, you don't. And we actually have a slide that's going to discuss that. You don't need to know the diagnosis. You just need to allow yourself the time to let them express themselves as best they can and to build rapport, credibility. It's the same fundamental principles as any other kind of de-escalation. And look, the amount of training necessary to become a psychiatrist to make all these diagnoses is huge. That's not our role. Our role is simply to say, this is a patient whose spatial orientation, whose temporal orientation, whose ability to interact with us is altered, and let's see if we can meet them where they are. So that extends also to dementia, delirium, and delusion. And because we're all EMS providers and sometimes these things get confused, a quick review: dementia is a very slow process. It is chronic and it is deteriorating. It may or may not be associated with age. It depends. Usually it is, but not always. And Alzheimer's is the most well-known kind. Remember, in people with Down, syndrome, dementia happens much earlier than with others. Delirium, unlike dementia, is a rapid onset. It's acute and can be reversible process. And so our role is to consider that, and based on the history, determine, is this dementia or is it delirium? If it becomes clear it's delirium, then we're also looking at the underlying issues. You know, is it an elderly person with a urinary tract infection? Do they have metabolic disease, etc.? And finally, delusion is simply an inability to accept and integrate a reality that we know is true, that they know is true, despite the fact that they accept the facts as being true. So, you know, if they look at their watch and it says it's 6 o'clock in the morning and they look outside and the sun is out, but they are still hellbound to telling you it's dark, that is a delusional fact. We treat these empirically. We make sure that they stay safe from harm, that we stay safe from harm, and verify that if these are people that are suffering from elder abuse, we need, or need for social services, that we are mandatory reporters. We talked that before. And we de-escalate again by reorienting and grounding. We're almost at the end here. I just want to talk about the PTSD crowd real fast. They've been exposed to either a single traumatic event for them, or repeated stressors that has created a locked space within their mind that keeps coming back under a certain set of triggering conditions. That can be violence. Either they are a witness to violence or they're a victim of violence. It can be that they were abused, either as a child or as an adult. They can be a victim of a disaster. It can be workplace related. So PTSD is very common in what we do. And we know that, and we are trying to address it, but it is still under the table in many cases. And we must recognize that what we do, this constant exposure to traumatic events, this vicarious trauma that we were talking about before, and real trauma. If we see somebody who is, you know, who kills himself in front of us, the list goes on and on, who hurts somebody else in front of us, these are traumatic and abnormal events. And we have to recognize that it takes a toll on our psyche. So our brethren in the police department, physicians, nurses, healthcare providers are all very much prone to this workplace-related PTSD. And finally, military veterans, this is the largest group, and people who are post-conflict specialists. So either they're working in the media, again, I only refer to now as the people that are covering the situation in Turkey, where they've covered wars. They are exposed to chronic stressors as well that can manifest as PTSD later on. And so what I'd like to do is show you a video. The importance of approaching with care, especially in the military or law enforcement communities. And Dennis can speak to this. I mean, these are people that have been trained to create a winning scenario in a conflict, right? They're trained to kill. And if they mistake the situation for a life-threatening attack on them, they will act accordingly if they're no longer part of this reality. Dennis, you want to say something to that effect before I show the video?
No, just that a lot of us, I'm sure Scott's the same way as you have here, that just hyper aware of everything, and us not showing compassion to them, open hands, things along those lines can wind up causing us problems. So just keeping us calm as we respond to them, maybe having someone that they know show up and be able to talk to them, a former police officer that they know, another member of the military, someone along their own level may wind up being of some assistance to help them out.
Absolutely. And
so I took a call one night, came out as assistant police with a suicidal patient, military veteran. I get there, everybody was nice and calm. He was leaning up against the car smoking a cigarette. But first thing the police said is, he's not going anywhere with us. I said, okay, so I identify myself, and he just kept calling me captain, and I lean up the car and I start talking to him, and he's telling me what his situation is. And I ask him, well, where do you want to go? Because I can't let you go back home because you use the magic word that you want to hurt yourself. Where can we go? He said, I will go to the VA. I said, all right. I said, that's not a normal hospital that we go to. I said, but I'll try. I said, if I can't get you into the VA, will you at least go down to university? And then tomorrow morning when the VA opens, because it was kind of late at night, like 7 o'clock, I said, then would you agree to walk across the street and check yourself in? So I made a phone call down to the VA and actually learn, for those providers out there, they cannot take an EP. But if he were to walk in and voluntarily take himself in, they'll be able to process him. And so we got down to university. Charge nurse obviously wasn't very happy that we passed, 8 hospitals to get to her, but that's what he agreed to. Documented, took him there, and pretty sure the next day he went over. So again, it's okay to think outside the box and go above and beyond for some of these folks, because if they're willing to get the help, do what you can to get it for them.
Yeah, absolutely. And they've served our country. It's our job to serve them. I think that's really important to keep that in mind. Recognize that sometimes, frequently actually, they are armed with a weapon. Typically it's a knife, and sometimes it's a firearm. This is we're not going to cover this slide at all. That's not the reason why I put it in there. But this is what needs to be check marked. It's the criteria for PTSD according to the DSM-5. And so, people who are seeking help and they want to get coverage and they want to get appropriate psychiatric diagnosis, there are so many boxes they have to check, and that causes a huge amount of frustration for many people. So just an aside. All right, quick video here, and let me turn off my stop video.
We get a call basically of a man with a weapon.
You're white male, approximately 30 years old, wearing a black hoodie and a military-style hat.
They give me a description. Where would he last be?
Sitting on the curb just prior to the parking garage.
They think he has a handgun on.
As Officer Richard Jones of the Pueblo Police Department walks up,
Hey, put your hands up.
he sees the man turn toward him with gun in hand.
Put the weapon down. Don't move.
Jones has his own gun out and ready.
Put the weapon down. Put the weapon down. He's not looking at anybody, not doing anything, not saying anything. He's got a 1,000-yard stare. Put the weapon down, sir.
As Jones continues to yell, the gunman walks toward him, and Jones sees he's wearing a sweatshirt indicating he's a veteran.
Come on, man. One back to another.
Jones is not only a CIT,
Lost the audio, Coast.
holding the loaded semi-automatic handgun stiffly at his side, and Corporal Richard Jones is hoping he does not raise it toward the officers.
Please drop it, brother. We've lost too many already. I know you're hurt, man. I was too. But I went about 4 months ago. So let me help you, please.
Despite the pleading, the man keeps asking Jones to shoot him.
I can't do that, man. I can't do that.
Suddenly, as Jones tries to move the conversation to appeal to the man's religious faith, the man puts his hands together on the gun as if he's going to raise it to fire.
You believe in Jesus Christ, brother? Don't do it. Don't do it. Shoot me. No, don't do it. I was in your shoes a few months ago, brother. It took everything in my body. Now I'm 6'5", 300-pound paratrooper. Took everything in my world to call the VA and to finally get the help. And I got the help, but I want to help you, man, because I'm tired of losing brothers and sisters. But I can't help you if you don't help me. Okay? The Lord sent me here to you today. He didn't send one of these other guys. He sent me as a vet to you to help you because I'm there. I'm in there.
After nearly 11 minutes of having his gun leveled at the man, pleading with him, the tense standoff finally ends.
Just drop it.
Jones knew he had succeeded in saving the life of a veteran just like him, who was in a mental health crisis. The relief was overwhelming. After gathering himself best as he could, he went to the fellow vet and hugged him.
I'm gonna tell you, I'm gonna get you some help. We're gonna start right now. I'm gonna get you over here to Parkview, and we're gonna get you taken care of, okay? I love you, bro. Good job.
Okay, so that
Wow.
that video encompasses everything that we've been trying to talk about here. It shows somebody remaining relatively calm under the circumstances. It shows the building of rapport and credibility, using one person to lead the negotiation, finding somebody who was able to identify with the victim as well as allow the victim to identify with the negotiator. It showed the importance of empathy. It showed the importance of reflective and active listening. And ultimately, and arguably of equal import, it showed how affected the police officer, the de-escalator, was, how emotionally taxing that was on him, especially since it had a happy ending, but how intensely, what an intensely emotional event it was for him. And so when we talk about trauma-informed care and vicarious trauma, this is what we are putting ourselves through. So a stunningly good negotiation with a great outcome. And, just a great job. I take my hat off to him and to the veteran who was able to reorient himself enough to recognize that he could get help. So, okay. And then pediatrics, simple terms, set context and limits again. And one of the great things, if you don't know if a ped is having an emotional issue, ask them, can you make a face to show me how you feel inside? You know how we use the faces to determine if a kid is in pain? You know, we have the smiley face. Let me turn my video back on. We have the smiley face with the smiles and the frowns and so forth. But a child can do the same thing with their face. And it's a great way to build rapport with a kid. You know, make faces with them. Tell me how you feel inside and make the face. Consider keeping the child with the caregiver or parents, or consider removing the child from the parents and caregiver if you suspect abuse. Do not articulate your suspicion, but simply have another partner or somebody else in the team occupy the adult with the responder. Remember, we are mandatory reporters. And we are almost here. Language barrier, real fast. 1,000 years ago, I used to work at EMRC part-time, and we would call into language translators. When I called EMRC the other day to verify they're still doing that, she had no idea what I was talking about. So I explained to her that that is a capacity that they actually have. Johns Hopkins has a 24-hour medical translation service. That's the telephone number. You're welcome to copy it down. Or you can tell EMRC to call the Johns Hopkins 24-hour medical translation service. So there is no reason why you should not be able to communicate with somebody from any language. They have 214 languages or something like that available on call 24 hours a day. Recognize also that there are apps out there, Google Translate, et cetera, but from a legal perspective, if somebody is not a certified medical interpreter, you run the risk that the information that you are acting on to provide medical care may be wrong information. So that a well-meaning person who tells you that they can speak a language, you have no way of verifying what they are saying or what they're not saying. You don't know if they are influencing the history, or if they have the capacity to understand the importance of a question that you are asking them from a medical perspective. So from a legal perspective, you are much better off getting on the phone and having a certified medical translator talk to you. And by the way, obviously, if you're on EMRC and they connect you, it's being recorded, which can only serve to protect you.
Coach, somebody
yes.
wrote, I work with parents who have lost a child and many have PTSD.
Yes.
Totally true. And then I also want to remind Baltimore County Fire Department has a language line that's available via your cell phone. So I just put that number in the chat too.
Oh, terrific. Thank you. And yes, the loss of a child is a horrific source of PTSD. Thank you for sharing that, and absolutely correct. There was a very tragic case of remember I was talking earlier on about the concept of not saying I understand. There was a labor and delivery nurse who herself had a stillborn child, and when several years before this incident, and parents lost a child in labor and delivery process, and the nurse went over to speak to the father, and she said, I understand. And there was no way for the father to know what the labor and delivery nurse had gone through, and he completely blew up at her. And it was a horrific event. So yes, the loss of a child is a tremendous source of PTSD and heartache, no question about that. Ethanol, opioid, and drug abuse. There are specific protocols that are instituted. The SEWA protocol is used for withdrawal of alcohol. The COWS protocol for clinical opiate withdrawal scale. This is outside the purview of our practice, but know that we can tell patients who need to be de-escalated that there are protocols specifically designed to address their needs, that there is help for them and there is hope for them, that they are not going through this alone, and that there are protocols that are designed to get them to the other side of their addictions. And then a fundamental component of all of this is do not expect rational behavior from an irrational person. It's hard for us to hear, but that's the case. And finally, with all this talk about mental illness and de-escalation, don't forget that there are other medical conditions that we have to treat per protocol. You need to know and verify that you are dealing with a mental illness and not seeing a manifestation of a medical problem, because medically and metabolically mediated behavior can cause escalating conditions. I recognize the simple things that we deal with on a day-to-day basis, diabetes with hypo and hyperglycemia, strokes, masses, lesions, tumors, inflammations, thermal injuries can cause issues that are neurological and can cause changes in mentation or behavior. Thyroid, acid base, we know all these things, sepsis, toxins. And finally, the point that Scott made absolutely correctly, don't label or don't make a new diagnosis of mental illness. Leave that to somebody who has far more training than we do. Just put it into your list of differential diagnoses as we treat these people. And just to sum up, situational awareness matters. Just because I have a disability or an apparent disability doesn't mean they can't be dangerous. People who, especially veterans, but other people who are confined to wheelchairs, who feel unsafe because they are perceived to be weaker as a result of their disability, can and do carry weapons. And also remember that just because you don't have an apparent limitation on your abilities does not mean that you don't have a disability. So we need to verify that in our history and treat it appropriately. Treat them.
If I can comment on that real quick, Coach. So think about our environment, folks. Baltimore City had what, several hundred, 800, 900 non-fatal shootings last year. A lot of these folks are surviving. So a lot of these folks have traumatic brain injuries because of the incidents that they've had, that they've been through. And violence was their lifestyle before the injury. And so the injury may or may not affect their lifestyle afterwards. So just kind of keep that in mind and not just assume, as we're saying here, that just because they're in a wheelchair or in a bed that they don't have access, wouldn't have access, and don't know how to use, because clearly that's got to be a very big part of our environment. And then if we do recognize it, that's not our job to disarm and make a weapon safe, right? That's where we have law enforcement and other partners with.
Absolutely. And recognize people with disabilities are chronically given sources of frustration with their condition, with limitations, with lack of access to appropriate care, with lack of transportation. And frustration is remember the list that we saw early on, what causes violent behavior? Frustration certainly can lead to violent outbursts. So encourage transport, appropriate hospital referral, avoid refusals, especially at the end of shift. We all reach for the refusals. Please, please don't. This population needs our compassion and needs our medical expertise. We are clinicians and we owe them that. And then Scott talked about emergency petitions earlier on. And recognize one more thing about restraints. Between the chemical restraints and the physical restraints, the Corcoran Library, this is that British group that I was talking about before, they looked at the literature. 40% of all restraint-related deaths were caused by unintended asphyxiation during restraint. If you are involved at any point, in any capacity, with somebody who is restrained, whether it's law enforcement, whether it's you putting them on the stretcher, whatever the case may be, if you're involved with this, assign one caregiver whose sole job it is to monitor vitals, and preferably end-tidal CO2 because it gives you the results of of metabolism in real time, versus what is called for is the O2 monitor. That does not act in real time. There is a 30-second plus delay on that. And by the time the person stops breathing, you're playing catch up. So if you have access to an end-tidal CO2 monitor, and virtually all of us have those now on board the units, use those on every patient that gets restrained. It is inexcusable for somebody to die under restraint of asphyxiation, period. And a lawyer will tell you that. Okay, manage expectations. Don't only diagnose a cause for the condition, diagnose a source of an attitude. And these are your resources that you have post-incident. If you need to make a tactical withdrawal, do that stage, wait for additional resources. You've got Signal 13, you've got the button on board your radios. Ask for a medical box if you need one, it gets you additional people. Don't forget, you've got station officer, you've got EMS supervisor, you've got Baltimore County fire surgeons, you've got county PD crisis teams. Depending on the time of day, they've got multiple teams out there. They were hugely busy today. You've got EMRC, and you've got the National Suicide Hotline, which is 988. And that is not only for your patients. We all go through difficult periods. We all go through traumatic events. We all have difficult calls. If you feel that you are in crisis, talk to your colleagues, talk to your supervisors, talk to your peer support. And if you don't feel comfortable doing that, and some of us sometimes don't, call the National Suicide and Crisis Hotline at 988. Avail yourself of the resource that's out there for you as well. We've got the CISM teams, peer support services, clergy, and Department of Social Services. And this was the Cortical Wellness app that Baltimore County pays for and allows us to access. If you want that, it's downloadable. That was in one of the EMS office newsletters, specifically the one November 26th of 22. Don't forget about our protocols, what we're allowed to do, what we're not allowed to do, and when you're allowed to do it. It's your responsibility to know these. And we have ways of intervening. There are right times, right ways, and wrong ways, right times and wrong times to use restraints. It's in the protocols. The last slide, practice self-care and be safe. We are happy to answer any questions. I know it's late, and on behalf of all three of us, we very much appreciate your willingness to stick with us on this, what we feel is an important topic for keeping you safe and providing the best possible care to your patients. That's all I got on this part.
Awesome. Thank you so much.
Dennis, Scott, anything I missed that we should add?
No, just the next phase of this will be offering a full day program where we spend 4 hours going through lots of different scenarios and really diving down to a lot of these topics. And then in the afternoon, we'll do some role plays and give you guys some techniques to get you out of a situation. The end of the day, if we have to go hands-on to defend ourselves, all we want to do is just get away from the situation. We're not in here to get into a fight with anybody. We're not here to end a fight. So if we're going to defend ourselves, we'll give you guys some solid techniques that will get you out of a situation and allow you guys to get home safe at the end of the night, which is, again, what we're trying to do. So thank you guys very much, and we'll see you out there.
Any questions?
Do you have a date for that training? What are your thoughts on that? How do we get that out to members? How do we disseminate?
It'll be part of your Thursday night. We'll kind of offer it through there, and we can advertise it through there as well. It'll be a Sunday, because it is a full eight hours for us to do this properly.
One last question in the chat.
What's the question?
I wrote it down. Hang on. Can you hear me?
I can hear you. Yeah.
Yes.
Here's what I wrote. So we need to not forget that irrational people won't respond rationally, but we want to treat them with deep respect, like they're anyone and everyone else that deserve our best attention and effort. A bit of a paradox. Can you talk about that a little?
Define your question a little bit, phrase it a little bit differently. I'm not sure I quite understand what you're asking.
It's taken me years to understand that irrational people don't respond rationally. But one of the best ways, you're also saying earlier in class tonight that one of the best ways to help them is to absolutely treat them like they're anyone else. Or is that just our attitude from our internal selves that we're treating like as good or better than anyone else, as opposed to the conversation we're going to have with them?
Yeah, understand.
Make sense?
Yes, I understand. So when I say treat them like anybody else, I'm talking about we should be treating each other, irrespective of who the other is, with compassion, with respect, with dignity, with kindness. And so I think it's easy when we are dealing with somebody who's acting irrationally to go to a gut level and saying, hey man, you know, what's with you? Why aren't you paying attention to me? Why are you acting crazy? And all the other things that sort of inherently come out. And I think it's important that we keep that in check and we act in the way that I just described. I think that the rationality or lack thereof on somebody else's behavior should not determine how we interact with them. I think we treat everybody with kindness and treat everybody, meet everybody where they are. You know, it's interesting, Scott, when he was putting together a PowerPoint for the classes that we teach, he said something. He said, we treat people like ladies and gentlemen, not because they are, but because we are. And I think it's a very valid point. So if somebody is suffering from crisis and they're acting irrationally, okay, they're acting irrationally. We can still try our best to offer them the best we have to make them better, or to make their environment better, or to get them the help they need. Does that answer your question?
Yeah, that was great. Thank you.
Okay. Any other questions?
Well, I certainly want to give our thanks before I just stop this recording. Happy to stay on if others have questions. But needless to say, yeah, we're just so thankful for the work that you guys are doing. Thanks for spending 2 hours with us, sharing this information. Ashley put a link in the chat for the first training, if anyone's interested in watching that as well. So again, just my heart goes out to you guys. I'm just super appreciative.
Take care of each other, guys.